Good afternoon, and welcome to this final session of the first day of TIO USA 2026. I'm Michael Reardon. I'm Professor and Chief of Cardiac Surgery at the Houston Methodist Hospital, and I'll be moderating this session where we're really going to take on one of the more consequential questions in today's TAVR practice, and that is, how do we optimize valve selection and implantation techniques with the lifetime management of the patient in mind? I'm joined by my panelists, Dr. Howie Herman from University of Pennsylvania, Dr. Waleed Ben Ali from Montreal Heart Institute, Dr. Craig Bassman from Hackensack University Medical Center, and Dr. John Force from the Yale University Medical Center. We're going to start with Dr. Herman. He's going to set the clinical stage for us, examining the challenges, hemodynamic performance, and emerging evidence in the TAVR patients. So Howie, take it away for us.
Well, thank you very much, Mike. You can see I'm going to talk a little bit about the small aortic annulus, some challenges, the hemodynamic performance, and some of the emerging data from our recent presentation of the 3-year results of the SMART trial. These are my disclosures. So as I think most operators now know, small annuli are more common than I think we thought about 5 or 10 years ago, affecting approximately 40% of all patients in TAVI registries and TAVI trials. And most of these patients are women. They make up about 85 to 90% of the small annulus population, and 70 to 80% of women have a small annulus. Yet they have been somewhat underrepresented in the randomized trials, as you see, 30 to 45%. Whereas in the SMART trial, where we emphasized the small annulus as an inclusion criteria, 87% of the study participants are women. And that's important because women are underdiagnosed with AS, they're undertreated, they're, as I mentioned, under-enrolled in the clinical trials, and they have a different pathology and outcomes with both surgery and TAVR. Their disease is characterized by more fibrosis, less calcium, and more concentric remodeling. And as a result, they have a higher mortality with surgery and more complications with TAVR, and why it's so important that we study women as a separate group. It was on that background that we conceived of the SMART trial. This is a prospective, randomized controlled post-market trial at 83 international sites. And the rationale included the facts that women have a small aortic annulus, and that patients with a small aortic annulus are most at risk for the effects of any adverse hemodynamics. When we designed the trial, it was already clear from core lab studies that the Evolut self-expanding supraannular valve had better hemodynamics in the small aortic annulus than the balloon expandable intraannular sapien valve. And for that reason, we randomized 716 patients between those two platforms. The mean age of patients was 80. Women, as I said, made up 87% of the study population, and it was a low intermediate risk population. We published the co-primary endpoints at 1 year in the New England Journal of Medicine, but are following the patients through 5 years and recently presented the 3-year outcomes from the trial at the European PCR meeting. These are the two co-primary endpoints through 3 years. On the left is the clinical composite of mortality, disabling stroke, or heart failure rehospitalization. And you can see there was no difference between the two arms at 3 years, with a slight numeric advantage for sapien. In contrast, bioprosthetic valve dysfunction, a composite of hemodynamic and non-hemodynamic non-structural valve dysfunction, thrombosis, endocarditis, and aortic valve reintervention, markedly favored Evolut at 16% versus 54% with sapien. But more important than the composite bioprosthetic valve dysfunction endpoint is looking at the individual hemodynamics, which you see here at 3 years. Effective orifice area, aortic mean gradient, and Doppler velocity index were all markedly better with Evolut than they were with sapien. They were significantly better both above and below the median annulus area of 386 square millimeters. Remember, the inclusion criteria was an annulus area less than or equal to 430. The lower limit was 280 in this trial. And you can see the smaller the annulus area, the larger the difference in hemodynamic performance between the two prostheses. These are secondary endpoints at 3 years. There was no differences in mortality, heart failure hospitalization, aortic valve reintervention, even new pacemaker implants, all stroke, transient ischemic attacks, and endocarditis, although definite endocarditis favored Evolut as did prosthetic valve thrombosis. There was also no difference in echocardiographic AR, mild or moderate or greater between the two platforms. We utilized the definition of prosthetic valve thrombosis from VARC-2 because that was the only one published at the time the trial started. However, we subsequently went back and utilized the VARC-3 definition as well. And here you see the CEC adjudicated differences in valve thrombosis through 3 years with the VARC-3 definition. Overall, there were 22 events with SAPIEN and 4 with Evolut, and they occurred throughout the time period of study, 0 to 1, 1 to 2, and 2 to 3 years. And they were made up about 50% from clinical events in the middle bar and 50% from subclinical events. And I always would like to emphasize at this point that subclinical events are not benign. They are subclinical, but they have implications for patient care, whether it's additional testing, such as a CT scan, changes in their anticoagulation regimen toward anticoagulation from antiplatelet regimens, and potentially later effects on structural valve function. And in fact, this was not a new finding. Subclinical leaflet thrombosis has been reported to be 50% higher with SAPIEN, as you see in this meta-analysis, compared to Evolut. And in this meta-analysis, which had much more power to examine clinical endpoints, because it included 25 studies, it was associated with a 2.5-fold excess risk for stroke and TIA. A second thing that we were very interested in the SMART trial was prosthesis-patient mismatch. And in this study from the TVT registry, some of the predictors of PPM are shown, and they include women, valve-in-valve procedures, and small valves. On the right are the differences in the SMART trial between SAPIEN and Evolut, both for severe PPM above and for moderate severe PPM below. And for the combination, you can see it was 10% with Evolut and 35% with SAPIEN. And one important aspect of PPM that is always worth emphasizing is that it takes time for these hemodynamic effects to have an effect on outcome. Here on the left, you see a meta-analysis of 80,000 TAVR patients showing that severe PPM was associated with a 25% increase in mortality at 5 years, but the curves don't really start to diverge until 36 months or 3 years. And that's the time point we're just looking at right now in SMART. So it wasn't too surprising that we didn't see an effect of hemodynamics on clinical outcomes at this point. On the right, you see an analysis recently published from the Cedars group looking at PPM in very young and low-risk patients, all with SAPIEN 3. And you can see yet again that the combination of moderate and severe PPM was associated with a 2.5-fold excess mortality at 5 years. But again, the curves didn't really start to separate until 3 years into the analysis. On the bottom right is the effects of LV mass index and change in absolute change in LV mass. And you can see in both cases, it took 3 years before there was separation of LV mass, suggesting a potential pathophysiologic mechanism for the increase in mortality. On that background, we examined a prosthesis-patient mismatch in the SMART group at 3 years. Here you see the VARC-3 moderate to severe PPM incidence at 30 days. Important to remember that was 10% with Evolut and 33% with SAPIEN. We then did a landmark analysis from 30 days, comparing the patients who had PPM with those who did not have PPM. And you see in the middle, the forest plot showing that there was an increase in mortality for the combined group of Evolut and SAPIEN for all-cause and cardiovascular mortality if they had moderate or severe PPM, and also individually for SAPIEN. On the right are the KM curves showing that difference at 3 years. Very importantly, we adjusted these analyses for age, sex, COPD status, renal function, and LV ejection fraction and stroke volume index. And that's important because there's been this discussion about measured versus predicted prosthesis-patient mismatch. Remember, measured is when we look in the patient, an individual patient, using echocardiography, and it can overestimate the incidence of true PPM because it may include low-flow patients. But it does tell you what's going on in the individual patient. And low flow is also an independent predictor of bad outcome. And you can see, though, by 30 days, most of the normalization in low stroke volume or low flow patients with AS has normalized. And that's the reason that we tend to use 30-day assessment of ppm. And that's what we did in this analysis. In addition, we then controlled in the analysis, we did an adjustment for stroke volume index. So a double assessment to look at stroke volume index as a predictor of ppm. The alternative is predicted ppm, and this provides a theoretical value, but also uses echo to calculate ppm. It's a core lab measure of echo gradients and stroke volume, but then it applies this group mean to individual patients. And so it's really no better than what we did, and in a lot of ways worse, because it can't account for inadequate and asymmetric prosthesis expansion, differences in leaflet material within the frame, and recoil. So to conclude, impaired functional performance of aortic prostheses, no matter how you measure them, individual hemodynamics or composites of those, it's associated with adverse outcomes, including mortality, heart failure rehospitalization, and valve durability. The patients with a small aortic annulus, mostly women and younger patients, are at greatest risk. At 3 years of follow-up in SMART, comparing the two Evoluta and Sapien platforms, we had similar rates for the clinical outcome composite, but significant less for ARC3 clinical and subclinical thrombosis. All of our individual and composite hemodynamic measures remain superior with the Evolute platform, including a markedly lower risk for prosthesis patient mismatch. And in an exploratory analysis, moderate or severe ppm at 30 days was associated with higher all-cause and cardiovascular mortality. So the decisions for TAVR versus SAVR and the choice of TAVR prostheses are complex and require both a heart team approach and shared patient decision-making. These findings support the importance of minimizing ppm whenever feasible and emphasize the importance of the SMART comparison continuing through 5 years of follow-up. In patients with a small aortic annulus, I think additional considerations should include operator experience with aortic root enlargement, as well as their experience utilizing multiple TAVR platforms. So I thank you for your attention, and I look forward to the discussion.
Well, Howie, thank you for that really great update on the SMART trial and some of the problems we face when we treat the small annulus, which applies both the TAVR and the surgery. And to build on that foundation, Waleed is now going to take us through a superannular approach to TAVR with a recorded case for us. So Waleed, go ahead and take over and show us your case.
Thanks. Thank you for the invitation. So I have no disclosure for this presentation. So basically, I'm presenting today one patient that we enrolled 4 years ago for in the SMART trial that Dr. Howard presented right now. It's an 8 years old lady. Yeah, as you see, it's 70 kilos with 163 centimeters and a BSA of 1.8 meters square. So as a past medical history, she has hypertension, dyslipidemia, but not significant coronary artery disease. We are not doing in my institution a coronary angiogram for all patients. The patient was admitted in our institution and a heart failure with dyspnea, NOAH class of 3. And in the EKG, we have a sinus rhythm with the first degree of AV block and the left bundle branch block with a QRS duration of 125 milliseconds. Yeah, the labs were normal for this lady. And the transthoracic echocardiography reviewed by the core lab showed a normal EF function, LV function, sorry, with a normal EF and aortic, severe aortic stenosis with an area of 0.84 centimeters square, a gradient, mean gradient of 42 millimeter of mercury, and a DVI of 0.25. Here, the pre-TAVI CT workup, we see very well that we have a very small annulus, aortic annulus, that fit in the inclusion criteria of the SMART trial with an area of 385. No calcification in the annulus on the LVUT. There is a non-coronary leaflet, a little bit calcified, so we choose to predilate this patient. And there is a small calcification in the STG that we take care to not touch with when we measure, we choose our balloon for the predilation. So the procedure was performed in November 10th, 2021 with an Evolut 26 as for the randomization in the SMART trial. We use in my center an optimized pro technique that you're seeing here. And you see on the right the final result with a depth of 2 millimeters in the non-coronary sinus. The procedure went very well, and the patient was discharged the day after without any complication, especially no conduction trouble complication, despite the left bundle branch and the first degree AV block in the pre-procedural workup. Now, this is the most important part of the presentation. As we know, we're putting this valve to help these people to get a very nice quality of life. So with using a self-expanding platform, we achieved a very nice hemodynamic performance as presented by Dr. Howard before. So as you see, well, the patient has a very nice EUA during all the follow-up. Now we are more than 4 years after the index procedure, and we have more than above 2 centimeters square of EUA and a sustainable low gradient of 7 to 8 millimeters during the follow-up. So to understand a little bit why we have this result and why we're choosing self-expanding platform for this small annulus, actually putting the commissure higher than the balloon expandable platform, you get better EUA opening, but you get also less shear stress applied on the leaflet. This will bring you a better hemodynamic performance and durability that you are seeing with this lady. I think Dr. Howard covered this before. The SMART trial presented in the EuroPCR, the results of the 3 years showed clearly that bioprosthetic valve dysfunction were higher in the balloon expandable platform group. And this is either for the hemodynamic structural valve dysfunction and the non-structural valve dysfunction. We saw very well that the Evolut valve gave to the patient larger EUA, lower mean gradient, and greater DVI. But the most important part, I think, that that SMART trial showed us, and we found the same and presented the same results 3 years ago during the TCT late breaker session with the XS trial from the French therapy registry, that the moderate to severe PPM impact severely the survival, and this is more significant after 3 years. So this is the presentation of a SMART trial case that we treated with a self-expanding. This showing very well that we can achieve in this small annulus population a very nice hemodynamic result that can be sustainable over time. And this also, as a surgeon, it's always a great discussion in the heart team to enlarge or not enlarge the root. Enlarging the root is not so easy, and this brings an additive mortality, especially in population aged over 75 years old. So thank you for your attention, and I would be happy to answer any questions.
Well, Waleed, thank you very much. I think we're going to pause now and have a little time for discussion. I would like to start a little bit with Howie. So, Howie, we've known in surgery for decades and decades that patient prosthetic mismatch really has a bimodal risk. There's a risk with the procedure, and then there's a long-term risk later on. In surgery, if I bring up somebody with severe patient prosthetic mismatch, they often have trouble coming off pump. They need inotropic support. We don't see that so much in TAVR because you don't have the same physiologic insult, but we have long-term data on TAVR that shows that by the time you get out to 5 and later years, the mortality really starts to separate. You're starting to separate at 3 years. What do you tell your colleagues about what's going to happen long term with this?
Yeah, I mean it's a good point. One of the issues that we always have in the TAVR world is that our randomized trials are underpowered and don't have long enough follow-up to examine specific small endpoints like prosthesis patient mismatch. So we're just getting now to the 7-year data on long-term follow-up in the randomized trials, which we're going to discuss today. But only a portion of those patients had a small aortic annulus, and only a portion of them had prosthesis patient mismatch. So it's very hard to show that in a TAVR trial of 1,000 patients followed for 7 years. Registries, large meta-analyses all show that hemodynamics matter and that prosthesis patient mismatch can affect long-term outcome, including structural valve dysfunction as well as mortality over time. So I do tell patients that all other things being equal, I'd rather have a bigger valve than a smaller valve.
We always say in surgery, the first cut is the deepest, meaning your first opportunity to treat somebody is the best opportunity to treat somebody. Well, do you have any comments for us about, are there any implantation techniques that you think are important to really help optimize your hemodynamics with this valve? Does depth matter to you? I know you're using you're using commissure alignment in your case, but do you have any other advice for those that are using this valve to optimize the hemodynamics?
Thank you for the question. I think we have, as in this case, we haven't to hesitate to predilate because this will help. Even I know that there is probably predilation is associated with higher risk of stroke and higher risk of conduction trouble complication, but to make place to the valve to expand well. And I think we don't have to finish with the valve under expanded. So don't hesitate to post dilate the valve if it's needed. Because as you said, from the beginning, we treated the patient from the beginning to have very nice results actually, and we have the performance of the valve had to be optimal. Otherwise, we cannot argue that we don't put a SAVR or don't operate the patient because if we have to end up with a very nice hemodynamic performance. So as I said, and I think this will be covered in the second part, to put it higher is good, but it's bring also other discussion for the lifetime management for a younger patient. Here in my case, it's 83 years old, so that was not a big matter. So we put it as higher as possible, and we try to predilate, post-dilate if needed to expand the stent at the maximum. In the post dilation, please be cautious, and especially in the team that used a non-compliant balloon, to not tear this higher commissure that we saw together, because this will bring, unfortunately, aortic regurg later in the follow.
So, we saw one thing that occurred in both the low risk trials and what Dr. Herman represented to us, and that was a higher rate of valve thrombosis in the balloon expandable valve versus the self-expanding valve. And I've become convinced that we often have underexpanded valves when we leave. One of the differences is one has a cobalt chromium frame that can't keep going out, and one has a nitinol frame, which will keep putting outward force. So, Craig, do you think there's do you think the design differences in the valve lead to this thrombosis? Is it the leaflet material? Is it underexpanded valves? Do you have any thoughts on that, particularly in a small annus, where I think it's harder sometimes to get full expansion than in some of the larger anuses?
Yeah, I mean, I'm completely agree with that, and I think my biggest thing is what we're learning more and more is that the expansion of the valve is extremely important. So a lot of the data from 8, 10 years ago, I don't know that we were expanding the valves as aggressive in pre and post dilation with self-expanding valves, and even now in short valves, sapien, a lot of people are doing double tap techniques and expanding the valves more. So I think that pinwheeling is probably our number one risk factor of leaflet thrombosis. And obviously, the bigger the valve, the less chance you're going to have of valve thrombosis. But I think what's changed the most over the past few years is what we know about expansion of these transcatheter heart valves. And that's why we're being a lot more aggressive on who we post dilate for better outcomes and potentially durability in the future.
Mike,
John,
can I
you're
ask
my co.
Howie a question?
Sure. Yeah. Fire.
Yeah, I want to ask Howie a question because I'm curious, given the high rate of patient prosthesis mismatch, was there a way that you could predict that from the baseline scans, the baseline BSA, other things? Have you been able to go back and look, because I mean, half the patients had it, half the patients didn't have it. And is there, as we sort of look to individualize, what we're going to do for the patient, any tips or tricks with that you've been able to gain from this that we might put into clinical practice?
I mean, the biggest one is the size of the valve. Obviously, if it is under expanded, which is more common with sapien than it is with evolute, that's going to affect the size of the final valve size. But you can predict you can do a prediction of ppm based on the valve that you're planning to implant. So for instance, for Dr. Benali's patient, he had a 385 square millimeter annulus. That would always be a 23 sapien and always be a 26 evolute. People have said, well, we biased the trial by comparing 23 sapiens to 26 evolutes. That was the whole purpose. That was the idea, that in a patient with a small annulus, you can put a 26 evolute in where you could only put a 23 sapien. And if it's further under expanded, you end up with a valve effective orifice area of a 21 or a 22. If you then take that valve effective orifice area, divide it by the patient's BSA, you can predict whether or not they're going to have ppm or not. So that's the easiest way to do it, is to predict what value you're going to put in, what your effective orifice area is, and then whether or not you're going to have ppm.
Well, I want to comment because one of my pet peeves, Howie, is when people tell me the SMART trial was comparing valve sizes. The SMART trial did not compare valve sizes; it compared annular sizes. And you were given an annulus and told to put in the best valve you could for that. So forget valve sizes. That's not what that trial compared. It compared annular sizes.
Right.
And talking about the different numbers is, yeah.
Yeah. I was just going to say, both arms adhere to the IFU for the valves.
Yeah. And again, it was the annular sizes that were being compared and which valve fit best in an annular size, not the valve sizes themselves. So, John, you were my co-PI in the low-risk trial. And we know that the smaller the valve you have, the more likely it's going to wear out sooner. And so when you move these small annuluses, what are you thinking about for valve durability, and how do you think about the potential for a second SAVR as you look at your patients, particularly since we see there are places in the country, which I find it hard to believe, where many people under 65 are getting TAVR valves. It's something I don't see at my place, but it's certainly reported all over the country.
Yeah, I mean, I think it will be very interesting as we follow the SMART data out beyond 3 years. I honestly, I hope we follow it out beyond 5 years, because you see, as Howie showed in the slides, that you continue to get further divergence even beyond 5 years. And so I think that will be helpful to know. I think, again, this gets back to a lot of individual patients. When you're doing a young patient, you're doing a patient who's 65 or 70. To be honest, unless that patient has a lot of other comorbidities, I think you're probably predicting that there is a good chance they're going to require another valve. Now, maybe it's when they're 80, maybe it's when they're 85, but there's a chance in that 70-year-old, I think, with any TAVR technologies, that they're going to require another valve. And there's a decent chance with surgery they're going to require another valve, especially when they're less than 65 if you're doing it. And so that's where I think understanding both getting the best result you can with your first valve and understanding what are going to be my options in 10 or 15 years when I need to address this valve, if/when it's no longer functioning well.
Yeah. Well, I think that's really true. And again, I think that's one of the things that we're all faced with now is we're being referred patients younger and younger and asked for TAVR. And certainly as a surgeon, these trials have certainly reinforced our need to do annular enlargement and make sure that we also come out with a reasonable valve size. Any other comments that I can get from the panel about our first two talks and presentations?
Yeah. Actually, I have a question to Dr. Howard, because we're seeing in both arms that the patients are doing well clinically. So despite that the performance of the valve are not so optimal, can you comment? I know that you tried to do the stress echo arm, but I think the number of patient was not so high to have any insight. But how we can design another study to show the improvement? Because I can tell you on the 8 patients that I put in the stress echo, there is a big difference between the two arms, despite that they have no difference in the clinical symptoms and clinical functional status in without effort.
Yeah, I mean, I think it goes back to two things. One is the comment that we already made, that it takes a while for hemodynamics to affect outcomes, and that it's not that surprising that we don't see that at 3 years. If I had one regret and one thing I would do differently if I redesigned the SMART trial today, is that I would have tried to get younger patients and had an exclusion for the elderly patients so that we could follow them longer. With a mean age of 80, following these patients past 5 years is going to have a lot of competing risks for bad outcomes that are unrelated to hemodynamics, and that may cloud our ability to see that, unless we do sort of exploratory analyses of the kind that we showed for the 3-year PPM analysis.
And those 80-year-olds, Howie, might not be very active as somebody that was younger.
Right. They don't. We tried to do a stress echo sub study, and we tried to do a stress echo sub study and couldn't complete it because these, 81, 82-year-olds did not want to come back for stress echoes. They didn't want to do stress tests, and it was hard to get any real substance and analysis there.
I wouldn't lose. Yeah, don't forget the majority of these patients are women, and they tend to do a lot better than us men as they go out. So we'll see.
Yeah, they do. They
Yeah.
live longer. Well, listen, that's a great discussion. I think we're gonna move on now, and I'm gonna give you a little bit of my perspective about optimizing hemodynamics, and hopefully put a little bit of what I consider the science behind what Howie and Waleed have presented to us. So my disclosure is I'm pretty much conflicted across the entire TAVR world, so it evens out pretty evenly. I'm just going to start with this. This is George Strain's echo database from Australia. They have a great echo database, over 280,000 patients linked to their mortality index across the country. And by going up 0.5 meter per second, showed that even mild aortic stenosis has a mortality effect on you. We don't treat it because the trade-off is not that great. But anytime you leave any kind of gradient over time, that's a mortality risk. Now, this is Gorland's work from 1955, when Gorland was working out flow across fixed orifices. I think this is important as we think about the small annulus. What Gorland did was look at aortic flow on the vertical axis, mean gradient on the horizontal axis. The blue lines are fixed orifice. The red lines are if you had fixed cardiac work. You couldn't increase your cardiac work. And what Gorland showed us was that at normal flow across the aortic valve, about 220 cc's a second, find the line for one square centimeter. What you see is it crosses that red line at about 40 millimeters of mercury. But if you go up to really high flow, 550 cc's, you're really pumping as hard as you can, you're well up over 100. So that's really important. Now, the other thing that's really important as you think about the small annulus is as you go from 0.2 to 0.4 to 0.6 to 0.8 to 1, it's not a linear increase in the gradients because it's related to the area, which is related to the square of the radius. And so until you get to a EOA of about 2, you really can't increase your flow without increasing your gradient. And this is going to be worse as you move to the small annulus. The small annulus, because it's a square of the radius, is affected more by this than the larger annulus. Now, there's some data that came out of the low-risk trials. Becky Hahn looked at this. Becky Hahn took the core lab echo data from the partner trials and the Evolut trials. And what Becky did was show that the SAPIEN mean EOA across the board was about 1.66, and the Evolut mean EOA was about 2.01. And these numbers do have some significance. Now, this is for all comers. She also made these tables. Now, we don't use SAPIEN and SAPIEN XT anymore. We just use SAPIEN 3. And what I do is draw your attention to a couple of things. I could not be part of the SMART trial because I had always told my group that a SAPIEN 20 has an EOA of 1.22, which is moderate stenosis, and we couldn't put one in. And so Neil Kleiman, my partner, and I said, well, if they got randomized to that, we just can't do it. We can't be part of the trial because we felt there wasn't equipoise. But most importantly, look at the Doppler velocity index. It's about 0.42. She did the same thing for the self-expanding valve, and you look at the Evolut R. Again, the EOAs are much bigger. The mean gradients are single digits. But more importantly, the Doppler velocity index is 0.61. And I think this is really important because this comes from the continuity equation, which means it's indexed both for that patient's flow and that patient's size. And what it says is the flow below the valve equals the flow at the valve tip. And the flow below the valve is the LVOT area times the LVOT velocity times index, the summation of all velocities across systole, and equals the aortic valve area divided by the times the aortic VTI. So if you rearrange those and divide the LVOT VTI by the aortic VTI, you get a Doppler velocity index. So Doppler velocity index is giving us that patient's aortic valve area as a ratio of that patient's LVOT. Doesn't give you an EOA because small people have little LVOTs, big people have big ones, but it gives you a ratio. And if you ask yourself if just hemodynamics you're thinking about, would you rather have your aortic valve 41% of your LVOT or 61%? That's a pretty easy one to answer. And as you realize as you get smaller, it means it's an even bigger difference. That really kind of tells you some of the reasons why I think as you move to a smaller annus, these become increasingly important. Another thing I hear a lot about is pressure recovery. And that, the pressure recovery measured in the cath lab is the right pressure. The echo is not the right pressure. They're both the right pressure. One estimates the pressure at the valve tips, and one is measuring pressure downstream. So what is pressure recovery? Well, pressure recovery comes from the first law of hemodynamics, that energy can neither be created nor destroyed. It can only change forms in a closed system. So if we think about the heart as a closed system, the ventricle squeezes until there's more pressure in the ventricle than there is in the aorta. That's an energy gradient. Remember high school physics, that's potential energy. As it moves to the valve, it has to accelerate. Acceleration is what? Kinetic energy. So if you gain kinetic energy, you lose potential energy, which is why you have a pressure drop across your valve. Once it gets through the valve, it hits the non-laminar flow of the sides of the aorta, and it slows down and gives up kinetic energy, so you get potential energy back and the pressure goes up. And for people with small annuses, they tend to have small aortas, and so the blood tends to slow down faster because it hits the wall of the aorta, it hits non-laminar flow faster. But when you look at this, does this really mean that there's a less gradient? No, it doesn't really mean that. What the heart cares about is how much work the heart has to do. And work is force over distance, and force is mass times acceleration. So you can calculate the amount of work that every volume of blood has to do from where it starts to when it exits the tip of the valve. Once it's out, that work's been done. You never gain it back. And as it goes downstream and the pressure goes up, you've just added to your afterload. So I hear this a lot in the small annuses. Oh, well, listen, I have so much pressure recovery, it's not the same gradient. It is the same gradient. It's still pushing against that. It's still doing the same amount of work, and you're adding afterload to it. Now, Howie talked about patient prosthetic mismatch. This was first brought to us by Ramatula, who worked out at Cedars. And what Ramatula originally said is that surgeons put in a valve that does not meet the physiologic needs of the patient, then they had patient prosthetic mismatch. Well, that was kind of hard to figure out what were the physiologic needs of the patient. So Peeberow and Dumasil did this study with 68 patients where they looked at mean gradient at peak exercise versus index orifice areas and looked for the bends in the curve. And these 68 patients is what gives us our definition of patient prosthetic mismatch. Severe being less than 0.65 centimeters per meter squared, moderate 0.65 to 0.85. It's really not mild, it's nothing after that. And there's fudge factors built in for obesity. These seem to change from time to time, so I'm not really going to go over them. Now, does it matter? Well, this is from Dr. Herman's work from the TVT, and what Howie showed us is that if you have severe patient prosthetic mismatch in TAVR by 12 months, it's already a marker for mortality. And I heard this a lot when I first started that. Said, well, you surgeons say it matters, but TAVR is different than surgery. TAVR is not different from surgery. The heart just cares about how big the hole is it has to shove blood through, not what the hole is made of or how it got there. Now, we have a lot of data from surgery. This is Fallon's work. Fallon looked at almost 60,000 patients that were 65 or older having isolated aortic valve, a lot like our low risk TAVR trials. And what Fallon showed is that any level of patient prosthetic mismatch, whether it was moderate or severe, had an increase in your mortality, an increase of your readmissions for reintervention and heart failure. So patient prosthetic is a bad thing. It not only shortens your life, but it makes you feel bad. And then Flaming showed us that patient prosthetic mismatch was a marker for early valve degeneration. And in fact, there are a lot of things that are related to structural valve degeneration: female gender, small body surface area, small valves. But there's only one thing that's related to late survival and structural valve degeneration, and that's patient prosthetic mismatch. So again, a bad thing. It makes you live less long, and it makes you live less well. And Blasey from Germany also showed us that if you had patient prosthetic mismatch, you could not get up to normal exercise capacity as opposed to those that did not have it. So again, it's going to limit you not only in how long you live if you follow these people long enough, but it's going to limit you as what you can do. Now, these may be subtle changes. And if people aren't really pushing themselves, they may report that, yes, I feel as good as the other guy. But again, as Valid noted, you put these people on a stress echo and you'll see a huge difference in their gradients. And that will make a difference over time if they are active people. And this is the low risk 30-day patient prosthetic mismatch from the trial that John Forrest and I had an opportunity to run, looking at moderate and severe patient prosthetic mismatch in the Evolut versus the partner arm. Not a surprise. We know that if you have a DVI of 0.41 versus 0.61, the patient prosthetic mismatch rates are going to be markedly different. And we've now used cusp overlap. Cusp overlap, I think, has allowed us to implant these valves a little higher and get better EOAs as well as decrease our pacemaker rates. So in summary, both TAVR and surgery, we need to choose a valve that has optimal hemodynamics and no patient prosthetic mismatch. If we don't, we're putting our patients both at an early risk and, more importantly, at a longer time risk for both mortality and for recovery. We need to implant to avoid complications like pacemakers. Overlap helps us that. And really, the first procedure is your optimal opportunity for lifetime management. And this matters even more in the small annulus because of the risk of patient prosthetic mismatch. And I'm going to stop there, and will allow us to move on to our last session, where Craig is going to present to us. We're going to close out with a recorded demonstration focusing on optimizing index valve implantation and lifetime management. So, Craig, take over for us.
All right, so we're going to talk kind of put everything together here, and we've talked a lot about lifetime management. So this is a case of a 74-year-old female, low STS. She's a healthy lady. She's a 74-year-old that looks like she's not dying in the next decade or two. She has some mild CAD. She's got, NYHA2 symptoms, and comes to clinic looking for an aortic valve replacement. EKG looks pretty good. LVH, QRS is about 110, a little bit of first degree, but otherwise healthy. And how do we kind of manage this? How do we optimize giving them that valve that's going to last them either the rest of their lives, or give us options to treat her through the rest of her life and not die of valvular heart disease? So here's the CT scan. I put it in big letters, the annular and perimeters and such. You can see there's a little bit of nodule of calcium in the annulus extending down to the LVOT. Nothing prohibitive in terms of TAVR, but you're getting an area around 344 of the annulus, perimeter around 65, and the LVOT narrows just a touch. The sinuses are big, but not too capacious. They're talking about 26 to 29 millimeters, and the STJ about 25 millimeters. So now we have this patient in the heart team clinic. We have our surgeon, we have our interventionalist, and the first thing we're going to talk about is, what do you want? What's the best option for you? SAVR versus TAVR. For this sorts of patients, I kind of go back to this chart, and you can cross out the right side of the screen with the BioCore and MitraFlow. We're not using that anymore, but you can really see that with this patient with a body surface area of 1.9, that if you throw in a small valve, and again we're talking about an average of around a little less than 21 millimeters. So typically, whatever the surgeon's going to implant, if you're not going to do a root enlargement, it's probably going to be a 21 millimeter valve or less, unless, of course, you're going to talk about some sort of root enlargement. And if you're not going to do a root enlargement, then there's a good chance that they will be left with some sort of patient prosthesis mismatch. Now, as Dr. Reardon had pointed out with the Rebecca Hahn paper, we also have options for TAVR. And, we have 3 different valves on the market with different EOAs. I think for an annulus area of around 345 within the LVOT narrows, now you're talking about maybe squeezing in a 23 millimeter sapien, which probably is going to look a little underexpanded, or possibly a 20 millimeter sapien that will be a little bit better expanded. Obviously, we have concerns with putting in a 20 millimeter sapien in a low risk patient that is otherwise could get surgery, or you have a 26 millimeter evolute. So those are really your two options. Then, the next thing is redo TAVR. And well, okay, now we have a 74-year-old, and I'm just going to assume that whatever I put in is going to fail at some point and that she's going to be okay. And she's going to need to do another valvular operation in her lifetime, hopefully past 85. But at past 85, hopefully she's still doing well. And she, at that point, is not going to get surgery. We're going to want to do TAVR at that point for sure. So, what do we have for lifetime management? So here's her coronary heights. You can see left, right, about a little, above 10, nothing too crazy high. You can see the coronaries were pretty normal. And the angle is 57, which is a little bit steep in terms of self-expanding. Sometimes I put this slide in because you can't 100% predict how this valve is going to cant, but nothing that seems too difficult for someone that implants these on a fairly regular basis. Here we have a DOSI, and I think that for those who utilize this technology, it's really good kind of understanding spatial anatomy and really trying to predict. I think it's the best thing we have other than our own eyeballs to predict what the lifetime management is going to be. So this is DOSI with a 20. This is a 26 millimeter sapien, 26 millimeter evolute, and a 23 millimeter balloon expandable implanted in size. And you can see here exactly if you've planted about 2 or 3 millimeters deep. I think this should play. For some reason not playing, but you could really, you can see three-dimensionally that there will be some space between the coronaries and a 26 millimeter valve, along with if you put a 23 millimeter valve inside a balloon expandable valve at about node 5, you still see that there's some distance between the left coronary and where you would implant that, along with the right coronary artery based on analysis. And, I think obviously there's questions about how valid this technology is. It hasn't, certainly we don't have enough data to track this through a lifetime yet. But I think it's helpful in kind of understanding what your risk is of a patient, and are you going to be able to get another transcatheter valve for redo TAVR later on. Next, we're talking about reducing procedural complications because anything we do in the lab, well, I mean, a stroke or something worse, that is probably the worst thing you can have for the rest of your life. So for this patient, we use cerebral embolic protection. She had a class 1 indication for cerebral embolic protection. That was, she asked about it in clinic. So I do believe that it does reduce disabling strokes, but anybody that asks about it, I always give it to them as well. Here we were talking earlier about kind of optimizing valve techniques. So here's again, minimum diameter of this is about 15/16. So we started with a kind of smaller balloon at about 18 millimeters. And then we ensure that our valve is commissurally aligned. You can see here that on LAO projection, hat marker to the outside. And one of the things you'll see here is kind of utilizing technology. What we use is CT fluoral fusion, and you can really get an idea of the spatial anatomy, where the coronary sit. Here's the cusp overlap technique, where you can see 2 dots on the left, 1 dot on the right, and you can toggle between fusion views to really show that you are commissurally aligned with this case, because that's going to be really important too. As I showed, 23 millimeter sapien inside this might work. And again, in 10 years, it might just be a 20 sapien, depending on the expansion and such. But that probably will work, but you can't quite predict what canting is going to look like. And so it's important to commissure align and to kind of preserve other future options. Here you can toggle again and just make sure that you are happy with your implant depth, also implant how the commissures are aligned. And, obviously the other thought is conduction. So, we have 2 kind of frames of mind where we have this, I show here one paper looking at the how to optimize TAVR with self-expanding valves. We want to be as high as possible to reduce pacemakers, factoring in the membranous septum length. But at the same time, the higher you are, the higher your neoskirt is going to be in the future. So with a higher neoskirt risk plane, that is going to be more challenging for redo TAVR in the future. But if you do plan, and you can see here, for this patient, about 3-4 millimeters deep, we thought that one, you wouldn't be too high for future corner if redo TAVR, and two, our membranous septum length about 5 millimeters. So as long as we can keep it under 5 millimeters, we shouldn't have risk of pacemaker in terms of our depth. And lastly, we talked a little bit about optimizing these TAVRs. You could see that there's just a little bit of under expansion. And so in order to kind of improve durability and for the sake of lifetime management, reduce any sort of PVL, even mild, we decided to post-dilate this valve to essentially optimize our valvular performance. Here's the post-dilation. You can see it expanding well. And on aortic angio, you don't see any paravalvular leak. Along with TTE, you see a nice valve, mean gradient of 5 millimeters of mercury. And so again, this is just kind of an example of how you perform lifetime management in terms of younger patient that has a lifetime expectancy more than a decade, factoring in valve size, factoring in lifetime management and redo TAVR options, and also thinking about how we optimize the index TAVR to reduce procedural complications and optimize how our valve is expanded and will perform later in the future. So again, thank you for having me. Wonderful, wonderful conference. I think I'm the last one to speak. So hopefully ending off on a fairly good note.
So that was a great talk and a great presentation, Craig. You know, it's interesting. I often get asked by some of my cardiologist friends is, you have somebody 66 and their anatomy is good for surgery, good for TAVR. They're okay with either one. What should you do? And the first thing I ask them is, tell me about your surgeons. Tell me about the valves they're sending back in the small aneurysms. If they're sending back 19 and 21s, you should just do a TAVR. Or maybe better yet, get yourself a new surgeon. We do know from the low-risk trials that surgery actually won hemodynamics in PARTNER 3, but has never won hemodynamics in any of the self-expanding trials. And I think, giving your patient an appropriate valve at the first go makes a difference. Now, we do have a couple of questions that have come in. One is there any difference in hemodynamic performance in the small annulus versus the large annulus with Evolut? Howard, you want to take that one?
Sure. I mean, certainly the differences are less. That's probably the bottom line. You start with a bigger valve area and you only get bigger. So that's the main thing. Hopefully we'll have some time to come back to that other question that you raised about invasive versus echo measurements. And I'd love to hear some discussion about that.
Yeah, again, that's if you want to start a fight at the bar, just bring that up, and and people will get talking about that.
Yeah.
The truth is, though, is that we live with echoes, and we make all of our decisions based on echoes. And we do hemodynamics to everybody because I'm old and I like hemodynamics, and we all know that we will see zero gradient with our Evolutes in the lab, and it'll come back 6 or 7 the next day, and it's because of pressure recovery. There is one more question, though, because we're pretty close to out of time. What emerging evidence or technologies should change how we approach the small annulus in TAVR? Anybody want to take that one?
I think
I'll say that
we're seeing. I mean, I'll say we are seeing valves with better hemodynamics coming along, both intraannular and supraannular, and that is changing things. Flow patterns are better in some of the newer valves. The problem is we don't have long-term data. We have a ton of experience with Evolut and Sapien out to over 10 years for most of us on the panel. Maybe not Craig, but everybody else. And we've been doing this for a long time. But those other valves, they're relatively new, and although their immediate hemodynamics are good, we know that you need longer term data to be sure that a valve's going to be durable.
But I will say,
I want to just
jump on with the best data we've ever had.
Yeah.
Go on, John. Sorry.
I think it's important to. I just want to say I think a lot of us may not know the surgical data, but I think we we need to be cognizant that surgeons have been trying to get great hemodynamics with their valves for a long time, and the great initial hemodynamics, which is why I think when we have SMART going out to 3 years and beyond, is going to be critical. Great initial hemodynamics in the surgical space at 30 days or at 1 year haven't always translated. So I think we do, as new technologies come on, we can't make our decisions off of sort of 30 days, 1 year. We are going to need some of that longer data.
Yeah. And I think we're
Yeah.
getting that. Well, I think
But I think this-
we've probably used. Go ahead.
No, just to say that the surgical community are more and more aware that they have to be more aggressive in root enlargement, to be honest, because and this is we learned from the partner trial. This is what I'm saying to my colleague. TAVR helped you a lot to be more smart, you know. So I think don't forget that we in both trial we have 3 to 4% of root enlargement, no more than that. But now I'm seeing my young colleagues doing Manugian, Boyang, name it. It's a lot of name, but the beauty is I don't think that the 19 and the 21 size is anymore on the surgical shelves, and I'm very happy to see this more and more.
The Y angioplasty has changed things dramatically. The Nixon Nugan, you can go up one size. The Yang, I can always go up 3 sizes. We don't put in 19 or 21s ever. Our rules: a female has never gets anything smaller than 23, a male less than 25. TAVR has taught that and has made us better surgeons without any question.
Yeah.
Do we have any other final comments before we bring this to a close, panel? Otherwise, I want to thank everybody for attending. I want to thank my panelists for part of this. This is the last session of the first day of TIO USA 2026. We look forward to some more great discussions tomorrow, and I want to turn things over to Azim now to close us out. Azim?